Hi, my name is Dr. Melissa Long of Abilene Christian University.
This study is going to talk about bowel intussusception in a collegiate basketball player. I'll be joined later by Long Driskill, our head athletic trainer, since he and I worked on this case study together. First off, we have no financial disclosures. So what is intussusception? Intussusception is a condition where the intestine actually telescopes into itself. You can see there's a picture on this slide that kind of shows how that happens. This causes an obstruction or a bowel blockage. This is really, really rare, like less than 22,000 cases a year. This is usually, when it is seen, it's seen in children under the age of 3. And if it is seen in an adult population, it's usually indicative of some type of underlying condition, such as a tumor or irritable bowel syndrome that may or may not have been diagnosed yet, and could be diagnosed because of the intussusception. Some of the common signs and symptoms of intussusception are nausea, vomiting, diarrhea, loose bowels. So a lot of the same stuff that we deal with the common flu or food poisoning. But in this case, oftentimes the bowel movement ends up becoming bloody and mucousy, and they call that current jelly bowel, which is then indicative of an intussusception. For this case, I'm going to be handing this over to Long Driskill, and he's going to tell you about our actual patient.
So for this case study, we're looking at a 19-year-old patient who is a collegiate basketball player, we said in the beginning already. So for this specific patient, he was in season, playing on the road, traveling with his team when he started to show signs and symptoms of some type of GI problem. He reported to the athletic trainer that was traveling with them, told him that he was having stomach cramping, vomiting, and then he noticed that he did have blood in his stool. So the staff athletic trainer contacted me, gave him directions to go ahead and take him into the ER in the town that they were in, and they actually came up with a differential diagnosis of either influenza or gastroenteritis as well. Based off of the symptoms that he was having while on the road, they went ahead and did a CT scan in the hospital because of the symptoms that he was displaying, and actually then started to show the intussusception of the small intestine bowel. The patient was monitored for 36 hours. He was given some medication as a muscle relaxant, and then the condition started to subside on its own. In the meantime, I traveled to the town in which he was in, transported the student athlete back to Abilene to then be following up with our team physician. In the meantime, he was put on a strict diet of liquids and then progressed to soft foods and then into solid foods as tolerated. After transport back to the home institution site, the student athlete then contacted me the next day and was having a lot of the same signs and symptoms and problems that he was having before after introducing some solid foods. Contacted our team physician, took him to see the team physician, and he was admitted into the hospital for further testing. He was then referred on to a general surgeon who obtained the CT report from the prior scan, and then decided to do a laparoscopic surgery to see exactly what was going on. Again, the small intestine had started telescoping back over itself in 3 different portions. So they decided to unwind, I guess you would call, or untelescope the small intestine and see if that would decrease the symptoms and help resolve the issue. Patient was in the hospital for about 36 hours. Again, started with the liquid diet and then moved into a soft diet and then introducing into solids. He did have to produce a bowel movement before he was discharged from the hospital, all in which he did. It all seemed to be working well, and then within the next 24 hours, the student athlete contacted me again and actually had the same problem over again. Went back to the hospital. At that point in time, they made a decision to actually go in to the abdominal cavity and looked for telescoping again. It wasn't there, but signs and symptoms were there of inflammation that it had happened again, and so they decided to resect that portion of the small intestine and send it off for biopsy. Like Melissa said before, there are some underlying conditions for this, all of which came back negative. No tumors, no other issues with the bowel itself from the biopsy report. From there, the patient was observed for 3 days, again released with a strict diet to follow, and progressed into soft foods and then solid foods. And actually, the problem has now resolved, and the patient is doing really well. I'm going to you'll see on the next slide some actual pictures of the telescoping. So there's 3 different sections, and you can see that where the small intestine is actually folding over the top of itself, the telescoping that they talk about. And in the first initial surgery, they basically just pulled that apart and left it alone to see if it would do it again. So at this point, I'm going to actually give it back to Melissa. She's going to talk to you about the uniqueness of this case, and then finish up with a summary.
All right, so why is this case unique? We talked about earlier how usually intussusception can be found in children under the age of 3, or maybe an elderly population, or those with an underlying condition. This doesn't apply to our patient at all. He's young, early 20s, otherwise healthy, had never had a previous history of any of this, no family history, and after all the resection and all the biopsies were done, he had no underlying conditions that were diagnosed because of this. So that makes it pretty rare. Additionally, when they do a surgery to correct intussusception, they have a really low recurrence rate after that, generally less than 10%. In this case, it not only reoccurred once, but reoccurred twice. So that's really, really rare, especially in this age group. And then also, after that bowel was resected and sent off, it was completely healthy, and there was nothing else going on, which again makes this even more unique. So what are some takeaway points for us as athletic trainers? First of all, we talked about those early signs and symptoms and that they're just like the flu. We deal with this stuff all the time as athletic trainers. Flu, food poisoning, especially when we're on the road, some gastroenteritis, things like that. But to be able to take a really good history and be in a space with your athletes or your patients where you where they can confide in you when they're having some signs and symptoms that maybe are a bit embarrassing, like bloody stool, most people don't want to talk about that. So making sure that we have that relationship with our athletes and that we're not afraid to ask those questions, but then also create a space where they're not afraid to have those conversations with us as well. So that's a really good takeaway for this, and something that we should especially tell our younger professionals that it's okay to talk about these things. Additionally, there's a dance sign. Dance's sign is the lower right quadrant, and there's an emptiness or a retraction in this area in patients that have an intussusception. So basically, everything below the blockage, the bowel has emptied, and therefore it creates this hollow sensation inside the lower right quadrant. So when it's pushed on, almost like McBurney's point, but closer to the ASIS, but still medial to it, if you were to press down, it would almost feel empty in that area. And sometimes in our skinnier patients, you might actually see a retraction on that side, inside that ASIS. So that's an interesting thing that I had never learned prior to this. Also, if you have a stethoscope and you can listen for bowel auscultations, you're going to hear very high-pitched bowel sounds, which is, again, not normal because usually we have lower-pitched and gurgling sounds with a normal, healthy bowel, but in this case, they're going to be high-pitched. And then the next thing that we need to take away as athletic trainers is just being able to coach our athletes or our patients. In this case, the patient was told to have a light diet, and in his brain, he thought that meant salad. So when he was starting to introduce solid foods again, one of the first things he ate was a salad. And as we know, that's a rough food. That's not something that we would think as a progression. But a lot of our patients might not understand what a real food progression is when you're trying to get back into the swing of things. So making sure that we're really clear about this is what a food progression is. Liquids, soups, noodles, soft foods, not necessarily a light diet, meaning a salad, because to him, calorically, that's light. But but as far as the texture, it's not, as we all know. So making sure we communicate that well with our athletes and our patients. And then finally, we need to keep in mind that reintroduction of food is going to be really slow, and that's going to affect their performance. In this case, obviously, our student athlete did not go back to practice. He took about 3 or 4 weeks off before he could return. But even when he did return, he felt slower than he did before because he had nutritionally been deficient for so long leading up to that. And so that was really frustrating for him. So making sure that we coach our athletes through that as well, and our patients through that, just acknowledging that there is going to be a lag and acknowledging that they are going to be healthy again. It just takes time for that body to catch up. So thank you for listening, and have a great day.